I've got a low-pitched Welsh accent, so sometimes I'm accused of being a low talker. It's a real pleasure to be here and to give this talk on behalf of the Oxford Biomedical Research theme of diabetes. All I was told was that I had to talk about diabetes in the heart, and I thought I'd try to expand it a bit to give you an insight into what I think the future of diabetes looks like. And I don't think it's too far away in the future. In fact, I think we're probably doing it now already. So my disclosure is that I worked in industry for the last 12 years in California. I brought 4 first-in-class drugs to market for diabetes and metabolic diseases. And the last year ago, I joined the Oxford OCTEM Centre, Oxford Biomedical Research Centre, because I believe that this centre leads the world in diabetes research, and I'll show you some of the evidence and data of why that's the case. I'm not going to gloss over this picture at the front, I nearly did. This is our atrium of where patients are seen in our outpatients clinic. And when you walk through the front door of that pinkish building there, you usually turn left. Left is to the outpatients clinic. You book yourself in and you wait then in that seated area. You do have the option of turning right, and right is where we do all the clinical research. So if you're ever involved in a research study, when you walk through the door, you'll actually turn right and go meet our research staff. On the second floor is a purpose-built ward where we do our research studies, and on the third floor are the offices of the researchers and the meeting rooms for discussion of the research and education, etc. So this is a purpose-built triangulation between clinical care, clinical research, and on the top right-hand corner is actually where we run our global outcome studies for. We have 50,000 patients around the world in global cardiovascular outcome studies. That's a third of the world's diabetes population. Their data is running through that unit in the top left-hand corner. That's why I say Oxford leads the world in diabetes. So I don't think there's anything more serious than diabetes. That's certainly why I'm involved in it and have been for the last 13 years. This is data from the World Economic Forum, and it's a wonderful frame for assessing risk. Up on the x-axis along the bottom here, it's the likelihood of something going to happen, and you can just about see above 20% is sort of where the axis ends. And on the y-axis going up is the severity of that if it happens, and it's measured in dollars, and it almost goes up to trillions of dollars at the top, number 6. And I've circled a group of diseases, or sorry, not diseases, a group of issues, global issues, geopolitical issues, as well as diseases. And in red are the 2 that are most likely, or not only most likely, but the likelihood of it has actually increased in the last few years. And you'll see the fiscal crisis, which we've all experienced. This is 2010 data. You'll see the slowing of the Chinese economy, which has already happened and is happening. And you'll see chronic diseases. And so number 31 is chronic diseases. And then if you look down the axis to chronic diseases, it says heart disease, stroke, cancer, chronic respiratory disease, and diabetes. And I'll show you why diabetes is top of that list in my mind. So going from a global economic impact perspective, a little bit more local, and this is diabetes in England, and it's been increasing year on year, and it's continuing to increase year on year. And the blue bar is the increase in the percentage of the population with diabetes. It's going to hit around 4 million by 2025. So that's about close to 10% of the population, and it's going to keep on increasing. It's quite significant. The concern about that is that diabetes is one of the great, if you like, associated diseases. A lot of things come with diabetes. Diabetes, for example, will increase your risk or double your risk for some cancers. It'll certainly increase your risk of heart disease by about 2 to 4-fold. And you see these as separate diseases listed on this chart for comparison. But actually, diabetes increases the risk of all those other diseases as well. You'll notice from coronary artery disease that we've made significant strides in the last 20 to 30 years with therapies, and the actual incidence of coronary artery disease has come down in the general population. In the diabetes population, it actually hasn't come down that much. And that's partly because the prevalence of diabetes is increasing. So the message is that diabetes is increasing, and with it will come other complications that are associated with this metabolic disease. In terms of event rates, what are the most common event rates in diabetes? A lot of people know about the microvascular disease, that is renal failure and nephropathy, or renal failure, and neuropathy, which is the nerve damage, and then retinopathy, which is the eye damage. I don't think as much focus necessarily is placed on the cardiovascular issues, and yet the cardiovascular issues actually dwarf the microvascular issues by some considerable margin. Chronic heart failure in particular is something that's not often picked up. Heart failure is a very common event when you get later on in life, and the frequency of heart failure, you can have multiple episodes before you actually end up passing away. And the association between heart failure and diabetes is a very strong one. So the event rate, this gives you some context of what are the events associated with diabetes. Now, these are the 15 health checks, and you don't worry, you don't have to read all this text. There's too much text to learn, but it basically means if you have diabetes, you should know these 15 checks, and you should be pushing all your healthcare professionals for all of these things. There's nice guidelines coming out towards the end of the year, which actually codify a lot of these things and fund a lot of these things. For the simple way to remember this, in terms of your own personal risk factors, it's A, B, C, and smoking. That's the way I sort of think about it. So A stands for your A1C, or your blood glucose. B is your blood pressure, and C is your cholesterol. If you get those three risk factors down as low as you possibly can from a clinical perspective without incurring any harm, and you stop smoking, you'll be in good shape. And I want to emphasize that glycemic control and tight glycemic control is actually not the most important of all of those. It's actually blood pressure and lipid lowering is probably more important than glucose control. However, glucose control is very important, particularly for microvascular disease. And this is a summary of the outcome trials that have come out in the last 10 to 15 years. And you'll see UK PDS heading the top. And this is a landmark study that was conducted here in the UK, led out of Oxford, pioneered out of Oxford, and it remains the evidence base for our treatment. And I'll go into that in a little bit more detail. And what the results of UK PDS really showed that lowering glucose, lowering A1C, improved microvascular risk or decreased microvascular risk. And over a period of about 15 years of follow-up, so a mean of 8.5 years, it actually reduced cardiovascular risk as well. In the original trial, it didn't reduce cardiovascular risk, but over subsequent follow-up, over 8 years or more, there was a reduction in cardiovascular risk of around about 15%. Also, in the subsequent follow-up, early glycemic control also reduced mortality. So that first line up there, UKPDS, pioneered here in Oxford, remains the global standard of which we base a lot of our practice for treating diabetes. The second one down is a US-based study, and that's actually in type 1 diabetes, and it's only captured here to show the sort of the consistency, if you like, between improving glucose control early and what it does to microvascular and cardiovascular risk. They didn't have a mortality benefit in that trial, but they certainly saw the improvements over the longer term. So the take-home message from those trials is start early in type 2 diabetes, treat aggressively, and try to sustain it there for as long as possible, and you'll hopefully receive these benefits leading out. The other 3 trials were done much later on in the disease, so these were not treatment-naive early people diagnosed with diabetes. These were late-stage diabetics. And the ACCORD trial in particular were patients with 10 years of diabetes, and they employed a different strategy where they actually aggressively lowered their A1C to 6.5% or lower. Their target was 6%, they got to 6.4%, and they just threw everything in the kitchen sink at them to try and actually lower the glucose. There was an improvement in microvascular events, no improvement in cardiovascular events, and what was concerning was there was an increase in mortality, all-cause mortality, and that's made us back off aggressive treatment in patients with late-stage diabetes, and I'll show you the guidelines now. So here's a schematic that sort of explains what I just verbalized, and it maybe a little bit easier to understand. So if time 0 with the dotted line going through the center of the graph here, if that's time 0, time of diagnosis for type 2 diabetes, and if you do nothing, your glucose control, A1C is your measure of glucose control on the y-axis going up the side and time across the bottom. If you do nothing, your glucose will gradually get worse over time, and with that burden of glucose will come microvascular risks and some cardiovascular risks. The UK PDS, if you like, took patients and they had a standard arm and then they had a treatment arm. And the treatment arm decreased this burden of glucose, this sort of carved out blue region. So in comparison to the top line, they carved out. And they did that for about six years. And then the follow-up study, which showed that early intensive treatment actually had benefit later, was 8.5 years. So a long time. The Accord trial, in contrast, took patients with 10 years of diabetes and really aggressively lowered glucose and kept them there at around 6.4%. And as I said, that did show an improvement in microvascular events, but actually increased mortality in some patients, or overall increased mortality. And that would be a normal glucose, sort of 6.5 to 7 is sort of what we would consider an aggressive treatment for maintaining glucose control. And 6.5 is now a diagnostic criteria. So if you're above 6.5, you have diabetes. If you're below 6.5, you probably don't have diabetes. And at Oxford, I've just added these on to show that we've got 2 global cardiovascular outcome trials. These are trials all around the world, and we just started out enrollment in China today in the EXCEL trial. TCOS is completed, and we'll present the results of that at ADA, which is the annual American Diabetes Association meeting mid-year, just to show that Oxford remains a leader in these diabetes outcome trials. ACE is a fully enrolled trial we've got going on in China. This is in collaboration with Bayer, and this is looking at acarbose in China. And this is in non-diabetics, so this is in patients with high cardiovascular risk, but with just a little bit impaired glycemia, but not in the diabetes range. And this is important, particularly you can imagine China is going to be one of the leading nations who's going to contribute to the number of people with diabetes in the world. And a pilot study that's going on right now is the Glint trial, and this is using metformin, a drug we all know very well, but this time in early pre-diabetes, so high cardiovascular risk and dysglycemia, but not yet in the diabetes range. And if that proof of concept trial goes well, we'll kick off a 14,000 patient study in the UK. So here are the treatment guidelines. These are the American Diabetes and the European Association of the Study of Diabetes guidelines, so joint guidelines from the US and Europe. And the recommendation, even though it's in small print at the top, is not to be underestimated. So healthy eating, weight control, physical activity, diabetes education is the cornerstone of diabetes treatment. There's a strong association with these factors and subsequent complications. And in fact, one of the best small studies called the Steno trial looked at multifactorial intervention and probably has the best results. It almost halved the risk of cardiovascular disease. A small trial, therefore it's not cited as much, but actually is probably one of the better long-term trials that shows that multifactorial intervention is the way to approach diabetes. So don't forget that top line. That is very important, and that's codified in the new NICE guidelines, and it's part of that 15 checklist that I put up in the beginning. But the first therapy is metformin, and you don't need to wait for any particular glucose level to start it. You should start it straight away. And it's got pretty good evidence behind it, largely from the UK PDS. A very good efficacy drug in terms of lowering glucose. And down the left-hand side, even though it's in small print, these are some of the criteria that we now judge medications in type 2 diabetes. So what is the efficacy of the drug? In other words, what's its ability to lower glucose? Does it cause hypoglycemia? And that flag, if you like, was raised first in the Accord trial, where severe hypoglycemia was associated with that increased mortality. Now, whether the severe hypoglycemia caused mortality or whether just people who get severe hypoglycemia are more frail, we don't know, but it's certainly associated, so we try to avoid hypoglycemia if at all possible. Weight, so if weight is the cornerstone management of type 2 diabetes, then we don't really want to use preferentially drugs that increase weight. We'd ideally like to help patients to lose weight or maintain their weight at least, and therefore use agents that actually help with weight loss or are weight neutral. And then, of course, always side effects. All these drugs have some side effects, and it's important to balance out those risks with the potential gains from glucose lowering and costs, which is a major decision maker often for many societal payers, and therefore access to therapy. After that, I'm afraid it gets like this. This is the reality. Basically, it's a choice. And the criteria don't change, which is good. Criteria on the left-hand side, efficacy, hypoglycemia risk, weight gain, side effects, costs. They vary in terms of how they rank, if you like, against one another, but really the choice is left up to the practitioner and the patient to decide together. Shared decision making and to decide which therapy is right for them. So very much a patient-led decision making, not a biomedical-led decision, and that's because we don't really have the evidence base to actually recommend one above the other. If you move on from dual therapy to triple therapy, you then get even more complicated. And if you did a clinical trial to actually try to work all this out, there'll be more than 120 arms in the clinical trial. So we're unlikely to actually get the answer, which is going to be the best combination. And this is one of the reasons for my talk today. Remember, is it time to get personal? In other words, what's the best combination for you as a person as opposed to the general population? So this is a patient in research event and a public engagement event, and it's wonderful to see this as the cornerstone of these algorithms, which is that our care needs to be patient-centered. In other words, we don't just prescribe what the doctor thinks and then let the patient sort of carry on. We should actually try to work with the patient to actually define, first of all, what are their goals, what do they want to get out of their life, and will this therapy help them do that? Will the support and structured education we give help them do that? Or really are they not bothered and they just want the decision to be taken over or handed back to the doctor? But I think starting off like this is very important, and certainly I imagine with this audience who are here this evening being so engaged, if you like, in research and the intent, you'd probably want this approach. So there are some things in here which are quite pointers. They want to gauge the patient's level of involvement. In other words, how much do you want to know about your diabetes and how much do you want to take control, and how best can we support you in doing that and make a shared decision based on the choices available. The bottom line is the final decisions will eventually lie with the patient, because if they don't really want to take the medication or the medication is not working for them, they're just not going to take it. So it's best to actually be empowered and informed. This is a schematic just showing the new classes in diabetes that have evolved over the last 50 years. So for a long time, if you like, since the discovery of insulin, which was a life-saving medication in type 1 diabetes, people used to die if they didn't get insulin back in the 1920s, young children often, quite dramatic if you like. And then with the discovery of insulin, they survived normal lives. And even today, there are gold medal winners who survive into their 70s and 80s and 90s on insulin for life. So that therapy is life-saving. However, we've added more to our armamentarium over the years. The UK-PDS trial looked at insulin, sulfonylureas, and metformin. And then since then, as you can see, in the last 10 years in particular, there's really been an explosion in the number of medications. And that's based on our increased understanding of the pathophysiology of the disease and our increased appreciation that one size doesn't fit all, and there are many ways to target glucose lowering, and this trend is likely to continue to increase. And here's just a really fine print list of the types of other targets that are in the pipeline, and this is increasing daily, as you can imagine. And with the sort of the genomic and omic revolution, we're starting to find more and more targets for us to look at. If you're going to do a Giblet slide to try and simplify that text slide, it'll look something like this. So still not simple at all. But just to say there are multiple organs involved, at least 8 or 9, including the brain, and they're all interconnected by what I would call neurohormonal signaling. So the nervous system speaks to all of these organs in harmony, in synchronization, and the hormones also all have different effects on different organs. And the question, I think, at the top of the slide is, for your diabetes, for your specific diabetes, which therapy or combination of therapies would work best for you? And I don't think we know the answer to that, but I think we're moving in that direction where we'll be able to give patients a better biomedical insight into what their particular type of diabetes is like. Let me just get rid of this box. So I think the future of diabetes looks something like this, and the advances in cancer have been quite phenomenal. When I was just a medical student back in the 1990s, there was one type of cancers. Those cancers now have been split into almost 40 different types by this ability to deeply phenotype the type of cancer. So it's not an unusual concept for us. And I think diabetes treatment will look something like this, and probably even more complex given the number of therapies and combinations of therapies that we can possibly put together. So I think it's going to go, and I think it already has started to move. So we used to think of diabetes as type 1, type 2, and then a sort of mixed bag of other, which were relatively quite rare. We now know, for example, that there's a condition called MODY, which is very sensitive to sulfonylureas, that if you actually have MODY, which is a defect in your potassium channel signaling in your beta cells, that you could actually be put on sulfonylureas for life. And never actually progress. So being able to identify that, and it tends to cluster in families, as you might imagine, is important. And actually Oxford leads the way in identifying that, along with Exeter. So how are we set up here in Oxford to prepare for the future, or if not, continue our leadership into the future? And I think this is a nice sort of schematic of the house we have at the Oxford Biomedical Research Centre in Diabetes. Not meant necessarily to be separate, but it is slightly separate. The Oxford Biobank is something that I also want to focus on, because I believe this is a tremendous effort led by Frederick Karp. So we have two core facilities, and that is our clinical research unit led by Sue Beattie, who's here in the audience, which is really where a lot of the human research and biomedical research occurs. And then we have a human isolation unit, which is one of the leading centres in Europe and in fact the world. It's in a global collaboration with some places in the States. And Oxford has this ability to harvest islets and whole pancreases for transplant and also for research purposes, which is extremely important. Our genetics and genomics group certainly leads a lot of the European efforts. Mark McCarthy is one of the leaders in the world, but particularly in Europe, on that effort. The translation trials group is something I'm a part of. That's led by Rory Holman, who leads all the global cardiovascular outcome studies that we've mentioned earlier. And we're developing our ability to actually do translational research and look at new interventions as they come through. And then the translation physiology group is led by Steve Goff and Patrick Rossman. So here's our CRU facility. There's currently 43 studies registered going through the unit. 10 of them commercial, 33 of them academic. So there's a close collaboration with commercial, and I think that's very important. I think that when you're talking about getting therapies to patients, it's actually the companies that take it through the regulatory process and then actually get it out there to patients through the payer hurdles and actually translate it into patient benefit. So I make no apologies, if you like, for my industry background, and no apologies, I don't think, for our collaboration with industry. I believe it's a duality of interests, not a conflict of interests. And if it's centered on better therapies for patients, then we should be supporting that. And these are conducted, as you can see, in very safe and comfortable surroundings, our own kitchen there, etc., and all the full monitoring you'd expect to see in a hospital. I mentioned Frederick Karp and the Biobank, which is not necessarily a core part of the BRC in OCDEM, but it actually is a very important effort. This is looking for 7,000 healthy volunteers around the Oxford region, between 30 and 50 years old. And what Frederick does is basically deeply phenotype them, so then we can recruit for further studies through this deep phenotyping process, and that would include genetics and other omic ways of measuring what your individual physiology looks like. And you perform physiological studies also to test to make sure that you're appropriate for that. So I think this for me is like laying the soil for flowers to grow later. This is sort of the basis, what you need to actually be able to enroll into targeted therapies studies later. I mentioned Mark McCarthy, who is one of the leaders in Europe and the world in genetics, and you can see by his list of collaborations. If you don't know anything, it's worth Googling the Innovation Medicine Initiative, which is an academia and industry collaboration. These things like DIRECT and Summit and STEM Bank are huge bioinformatic ways of looking across the disease and trying to find genes that are associated with disease and if you like, molecular signature patterns that actually may identify different types of diseases for us to actually target therapies against. So this is very much, if you like, leveraging the advancements in genetics and genomics over the last few decades. Steve Goff has got a particular interest in islet physiology and works closely with Patrick Grossman and Paul Johnson of the islet isolation unit, and has been long focused and good collaborator with industry. And you can see excellent both public and private partnerships under there. This is the Star Wars team, our isolation surgeons, and they're on call this week, so they carry bleeps and they get called to road traffic accidents, for example, people who have donated their organs, and if there's a pancreas that's they're able to harvest, they will harvest it, and then they'll use those cells for research and also potential pancreas transplants. So, as I said, Oxford is one of the leading centres in the world for that. And this is my group, or the group that I'm a part of. It's Rory Holman's group, but it's a group that I'm a part of. And this is the translational trial group. And what we do is we assess, if you like, and collaborate with industry to do proof of efficacy and proof of concept trials on new interventions that are coming through. So we want to know as early as possible, does this therapy work, and in which population is it best to work? And we want to try to help small companies often, but large companies also, accelerate the development of these therapies and speed their journey to patients. And you'll see down the bottom that our links are quite deep within Oxford, with other professors within Oxford, but also quite deep links with the industry as well. So in summary, I just wanted to say that diabetes is a global epidemic that threatens the economic development of many major countries in the world, if not the global harmony, if you like. It's a heterogeneous disease. The one-size-fits-all is unlikely to be the solution. And we're just at the start, if you like, of trying to tease apart the pathophysiology and personalize the disease. I believe that this is going to unfold in the next few decades. Personalized risk and prediction of risk for early treatment and prevention of the disease is clearly where we need to be focused. We don't want to wait until patients get diabetes. We want to give them well in advance some inclination of what their chances are of getting diabetes, and then build a whole prevention program around that, which includes medications early, as well as lifestyle interventions that work for them and that actually match their physiology. And I believe that individuals need to be empowered to know more about their disease, to help them predict and track their risk and make decisions as they move along. And I think in that way we can improve the outcomes. And a final slide is, as you walk through the doors of Octem next, if you turn in left, you can also turn right and sign up for our registers and see what trials might be available for you to get involved in. Thank you.